Today, we will be discussing a topic that is at the heart of acute care medicine, inotropes and vasopressors. We're going to discuss these two sets of drugs together because many of them have both inotropic and vasopressor effects. These drugs are life-saving and they are frequently used in states of shock, severe hypotension, cardiac failure, perioperative instability, in the intensive care unit, and also in emergency settings. Yet, despite their routine use, they are often misunderstood or misapplied. By the end of this session, we should be able to define inotropes and vasopressors and understand their receptor pharmacology, as well as to differentiate the commonly used agents. We should also be able to apply them appropriately in different states of shock and also recognize adverse effects and monitoring principles. So let's begin with the basic physiology. To understand these drugs, we must first understand blood pressure regulation. Blood pressure equals cardiac output multiplied by systemic vascular resistance, while cardiac output equals heart rate multiplied by stroke volume. Stroke volume is determined by the preload, afterload, and cardiac contractility. So hypotension can result from reduced preload, poor cardiac contractility, reduced systemic vascular resistance, as well as bradycardia. This is where inotropes and vasopressors come in. So by way of definition, inotropes are drugs that increase myocardial contractility. They primarily improve cardiac output, while vasopressors are drugs that increase vascular tone. That is, they cause vasoconstriction, thereby increasing systemic vascular resistance and blood pressure. It's important to remember that many of these agents have both inotropic and vasopressor effects depending on their dose. Now, a brief look at receptor pharmacology. And the first set of receptors we're going to be discussing is the alpha-1 adrenergic receptor, which is located on vascular smooth muscle, causes vasoconstriction, thereby increasing systemic vascular resistance and blood pressure. Another is the beta-1 receptor, located in the heart, causes increase in heart rate, cardiac contractility, as well as cardiac output. The next is beta-2 receptor, which is located in smooth muscle and induces smooth muscle relaxation, thereby leading to vasodilatation and bronchodilation. Dopamine receptors, located in renal, mesenteric, and coronary beds, and causes renal and mesenteric vasodilatation. V1 receptor, located primarily in peripheral arterioles. It is a G protein coupled receptor that is activated by vasopressin, primarily responsible for mediating vascular smooth muscle contraction, causing vasoconstriction and increasing blood pressure. Another is angiotensin 2 receptor type 1, which is primarily located on vascular smooth muscle, kidneys, adrenal cortex, and the heart. It mediates vasoconstriction, aldosterone release, renal sodium retention, and cardiac remodeling to increase blood pressure and fluid volume. Now, commonly used agents include norepinephrine. Norepinephrine is used as a first-line vasopressor in septic shock. It acts as a strong alpha-1 agonist, leading to vasoconstriction. It also has moderate effects on beta-1 receptors, which lead to mild increase in cardiac contractility. Its overall effects include increased systemic vascular resistance and increased blood pressure with mild increase in cardiac output. Clinically, it is used in septic shock and other types of distributive shock. It is also a first-line drug in most hypotensive intensive care unit patients. The adverse effects include peripheral ischemia, arrhythmias, and extravasation necrosis. The next drug is epinephrine, which is a non-selective adrenergic agonist. At low dose, it acts on beta-1 and beta-2 receptors, while at high dose, it acts on alpha-1 receptor. The effects include increased heart rate, increased contractility, and at high doses, increased systemic vascular resistance. Its clinical use include in cases of cardiac arrest, anaphylaxis, and refractory shock. Adverse effects may include tachyarrhythmias, lactic acidosis, and increased myocardial oxygen demand. The next drug is dopamine, which is less commonly used today. And at low dose, its effects are dependent on the dosage. At low dose, dopamine acts on D1 receptor, which causes renal vasodilatation, while at moderate dose, it acts on beta-1 receptor, which causes increased cardiac contractility. At high dose, it acts on alpha-1 receptor, leading to vasoconstriction. Clinically, it is rarely a first-line medication and is used in selected cardiogenic shock states. The problems of its use include high risk of arrhythmias and is a less reliable in mean arterial pressure control, and also it has worse outcomes compared to norepinephrine in septic shock. The next drug is Dobutamine, which primarily acts as a beta-1 agonist and also has a weak beta-2 effect. Its effects include strong inotropy, that is, it increases cardiac contractility. It also increases cardiac output and results in mild vasodilatation. Clinically, it is used in cardiogenic shock with low cardiac output and also in acute heart failure. It is important to remember that dobutamine may worsen hypotension due to vasodilatation. Hence, it is often combined with norepinephrine. The next drug is Vasopressin, which is a non-adrenergic medication. And its mechanism include V1 receptor activation, vasoconstriction, as well as water retention via V2 receptors in the kidneys. Clinically, it is used as an adjunct in septic shock as well as in catecholamine-resistant hypotension. The advantage is that it works even when adrenergic receptors are downregulated. The next is phenylephrine, which is a pure alpha-1 agonist. The effects include vasoconstriction with no direct cardiac stimulation. The clinical use include in tachyarrhythmias and anesthesia-induced hypotension. However, it can cause baroreceptor-mediated reflex bradycardia. The next is isoproterenol. Isoproterenol is no longer widely used today, and its effects are on beta 1 and beta 2 receptors. It has greater impact on heart rate, unlike Dobutamine, and is primarily used for bradycardia, and also it has vasodilatory effects due to beta 2 receptor activation. Another medication is Milrinone, which is a phosphodiesterase inhibitor and acts as an inotropic agent. This drug inhibits phosphodiesterase type 3, leading to the elevation of CAMP levels, which leads to increased calcium ions in cardiac myocytes that enhance contractility. They also cause elevation of cGMP, leading to vasodilatation, which subsequently causes a drop in blood pressure. They are used in cardiogenic shock as well as heart failure. Another drug is synthetic human angiotensin 2, activates angiotensin 2 receptor type 1. It is a potent vasoconstrictor and is used in septic shock as well as other distributive shocks. Now, how do we choose the right agent? In cases of septic shock, remember that the pathophysiology is reduced systemic vascular resistance. Hence, norepinephrine is used as the first-line medication. This leads to increase in systemic vascular resistance. Vasopressin may be added if the shock becomes refractory. Also, Dobutamine may be added if there is low cardiac output. As for cardiogenic shock, the main problem is reduced cardiac contractility. Hence, Dobutamine is given to increase contractility, while norepinephrine may be added if the patient is hypotensive. In hypovolemic shock, the primary treatment is fluid resuscitation, and vasopressors are only used after volume has been corrected. In obstructive shock, the underlying cause should be treated, and vasopressors may only be used as temporizing measures. The following are evidence-based pairs that should be remembered. Norepinephrine is superior to dopamine in septic shock and causes lower arrhythmia rates, while early vasopressor use may improve outcomes. High doses increase mortality, and therefore we should aim for the lowest effective dose. Shock treatment is dynamic, and therefore frequent reassessment is important. Now, consider the following clinical case illustration. A 65-year-old man with urosepsis presents with mean arterial blood pressure of 55 millimeter mercury after 3 liters of fluids. What is the next step? Why choose norepinephrine? And when would you add vasopressin? Drop your responses in the comment section.